Well, good afternoon, everyone. It's a moment of great honor and privilege for me to extend a warm welcome to all of you today to the Lower GI Live Web Air, organized by APELS, that is Asia Pacific Endo-Lap Surgery Group. So far, we have received 500 doctors and 150 nurses submission registration. And as a medical academic group, APEL has been organizing various types of physical training workshops for the last 5 years. But due to the COVID situation, we've moved on to virtual events in the recent year. And the workshop has inspired many doctors, nurses, and medical professionals in the industry. The host of this web day today is Professor Craig Lynch from Australia and Dr. Joe Fan from China, who has been making extremely great effort to organize a high standard interactive web there, focusing on the topic of lower GI surgery, how to improve Endo-Lap OR to achieve team success, how technology shapes the future Endo-Lap. The event capitalized our strength and realized our commitment to you all to cultivate intensive learning culture and enhance professional competency in the field of endo-laparoscopic surgery. Now, this 3-hour web air will put into 2 key parts. First half of the event will capture the essence from APEL's legendary workshop with the presence of notable speaker, Dr. Jiunn from Singapore, Mr. Vincent Chan from Hong Kong, Dr. Joe Fan from Hong Kong, Professor Yutaka Sato from Japan, Professor Philip Jiu from Hong Kong, and Professor Craig Lynch from Australia, to share their ways to be the best in OR and some mega technology trends which are transforming the future of Endo-Lap OR. As chairman of APELS, I look forward to the rapid growth of the society and wholehearted commitment to educate, train, and innovate in every aspect of endo and laparoscopic surgery. Once again, I welcome you all and sincerely hope that you will enjoy the program. I wish the webinar enlightens us all and provide us with practice approaches to deal with the everyday challenges. I look forward to seeing you all in the coming workshop, both online and in person. Thank you.
That's great. Thanks, Professor Lee. That was a very good opening. We're going to move on now to our first talk, which is Dr. Herng from Singapore. He's a laparoscopic and colorectal surgeon in private practice in Singapore. He's been a founding board member of APEL since its inception and very involved in the training. And today he's going to talk to us about 10 pitfalls in laparoscopic operations and OR setup, and maybe some things we can do better in that regard. Thanks, Dr. Lai.
Thank you, Craig. Good afternoon, ladies and gentlemen. I'm Dr. Jiunn from Singapore. I'm going to share my screen right now. And I'm honored to be starting first and sharing with you 10 pitfalls in laparoscopic operations and OR setup. Now, what is a pitfall? A pitfall is an unexpected danger or difficulty and usually not anticipated or prepared. So let's take a look at this video from years past. We were doing a low rectal transection. Right after that, you can see some bleeding, and my goodness, the staple has misfired. It's a pitfall, it's unexpected. But as usual, with any unexpected pitfalls in surgery, we try to troubleshoot, we try to galvanize what modified techniques we have, and there we are trying to do a manual purse string, all right, to get the circular staple in and still salvage the situation. So there we have it. We're quite happy. All right, circular staple has come in. All right, and then you can see us putting in the colorectal anastomosis from the top. All right, so this is the first part down, so we're quite happy with that. Next thing we do, we're going to do an air leak test because we do know, oh, there's a bubble. All right, so bubbling at air leak test. This is the second pitfall. All right, and we decided to troubleshoot it by suturing. All right, as you can see, every step and every pitfall, we can manipulate, we can do something out of the box, and we can salvage the situation. And as you can see, we do a colonoscopy to check for air leak from below, and the patient is well 3 months later. So really, what is good laparoscopic surgery? You need a dedicated surgeon, good skills and experience, knowing what your operating theater setup and procedure is like, and think out of the box. So my scope of my talk today is on all the pitfalls, the 10 pitfalls that we can think about for laparoscopic OR setup and surgery, some suggestions on solutions and safety, and a reflection. Really, we're going into some things to do with pitfalls for positioning, trocars access, laparoscopic instruments, dangers of energy devices and platforms, and laparoscopic procedures. So the first pitfall, a non-specialized OR team. Oftentimes you go into a theater, it's empty, and somebody asks you, what do you need us to set up, doc? And really, that is not the ideal. Every time you need to do a laparoscopic surgery, you need to configure again. It cannot be the case. So really, we need a specialized OR team that's dedicated to do your laparoscopic procedure day in and day out. They need to be specialized and trained support staff to set up so that you can get into theater like this, happy. That's me going to the theater every day, happy. Second pitfall is knowing what are the pitfalls of an OR setup in terms of patient selection, position, equipment setup. And really, for cases like what you see here, robotic surgery on the left and TEMIS on the right, if you don't get all these pitfalls sorted out, you do not go into OR happy. You need to make sure you know the necessary equipment, from the trainee down to the senior surgeon, monitors, cameras, recorders, insufflators, all kinds of devices, robot, transanal setup, lights even. You need to know everything, set it up, put it into a file, get your support staff to set up the same every time, down to the operating table, additional surgical equipment, and all the wires in laparoscopic surgery need to be linked and laid out safely. This is a common position of equipment of anterior resection. You can see the monitors based on where the surgeon and his assistant stands and the diatomy and energy, right? Patient selection. Another pitfall is knowing what patient do best with laparoscopic surgery. Those with chronic lung disease, severe respiratory or cardiac compromise may not be the best to do prolonged laparoscopic surgery. Locally advanced cancer, multiple abdominal surgery in obese patients, we have moved on to do keyhole surgery safely for the majority. Modified Lloyd-Davis in a steep transdental position presents itself with quite a few pitfalls. When you lie the patient in steep transdental, the patient can go into ventricular compromise, cardiovascular effects, cerebral edema for prolonged steep transdental. So you brachial plexus injury, down to lower limb ischemia. So you really want to mitigate how long the patient is in steep transdental, but you may want to adjust it to a less steep situation when your vision and laparoscopy demands it. The position will be like this for most of my patients in anterior resection, so that it's nicely, lightly flexed and you don't get entangled with the patient's legs when you are doing the keyhole surgery. All right. Similarly, we need to have padded shoulder pads, anti-slip mattresses to make it safe. Now, really, these are some of the safety measures, including deep vein thrombosis prophylaxis, and avoid prolonged operative time in a fixed position always. What is the third pitfall? Uncertain personnel position. A lot of trainees go in thinking that, oh, today we're going to be the first assistant, today I'm going to be camera person, where do I stand? It's always a fixed position. That should be critical to laparoscopic surgery, to have all your assistants and camera person all work in tandem and with a standardized position, ideal for equipment setup and ergonomics of the OR. The wrong position or change of position can occur once operation starts, but will result in a drastic change and movement of equipment and increase your OR time. Most of the time, the surgeon stands opposite to the site of pathology. I got a first assistant opposite me and my cameraman is next to me. The proctor can decide to be either here, there, or the first assistant. And this is some of the things that I usually do. This is quite standard for my OR. My support staff knows anterior resection, that's where I stand with my field of vision and my cameraman and first assistant. When I do a splenic flexure mobilization, I move in between the legs. We adjust the TV monitors as well as the wires a little bit. A right hemicolectomy I usually do in this position on the left side of the patient. And this should all be documented down and fixed in a file and should not be a pitfall for surgery. Pitfall number 4, what are the access and trocar pitfalls? Most GI procedures will require 3 to 5 ports in multi-port surgery. Now, one pitfall is pneumoperitoneum. You do know that increasing the pneumoperitoneum plus transdental can decrease your functional residual capacity by up to 15%. And that's why lung disease or chronic lung disease patients need to be looked after. All right. Increasing your pneumothorax pressure more than 15 to 20 mm mercury can decrease your cardiac output and increase a lot of complication rate. What are the other pitfalls? Camera port commonly can have a lot of problems, from obese patients, difficult plane of access, to small bowel injuries with patients with adhesions, bleeding and or mental injury, and even a simple thing as fixation needs to be get right. If not, you get a lot of gas leak and irritation And sometimes we use a balloon port like this to mitigate some of these pitfalls. Good practices for camera port. Very nice transverse incision for cosmesis. You can vary the location if there's previous surgery, subumbilical to supraumbilical, cleanse the umbilicals to prevent infection, stitch it down, get a meticulous closure to prevent hernia. Working ports, commonly, if we forget about them and end up with bleeding, especially, for example, even a surgery like appendectomy, you can get bleeding from inferior epigastric trocar damage, all right? Spacing the ports too closely will result in difficult chopsticks kind of movement for laparoscopic surgery. Spacing the ports too far apart, sometimes you can't reach the splenic flexure. And the same thing with securing your ports so that you can prevent leak and irritation and gas leak. All right, so these are some of the features of a good trocar for access. Now, if you're engrossed with the TME here, right here on the picture, you can see small bowel injury from the right iliac fossa port because we keep getting engrossed in the pelvis and forget about our ports. Next pitfall is instruments. Beware of instruments. They can be atraumatic grasping forceps, but guess what looks like on this video? So there we are, my trainee, we're doing a nice transection for a sigmoid tumor. So you can see the left hand is a bowel grasper, grasping a bit of bowel. We're getting a very nice view of the transection site. So the trainee is very excited. But guess what? On the left hand, he's holding to the bowel tightly in a little knuckle. And whenever there's a little knuckle or bowel, beware, even if it's atraumatic forceps, guess what happens after that? There is always some trauma. Thankfully, this bowel was supposed to be resected, so it's safe. Same thing, beware of heat from your energy devices. Thunderbeat is a wonderful device. I use it for almost everything. Adhesiolysis wise, you've got to be careful to keep it away from the bowel, like what we are doing here. And even a safer practice is to put a wet gauze so that you can mitigate the effects of the heat. Now, of course, be practical about it. Even if you're using a nice energy device, when you're doing a bowel to bowel dissection, perhaps a simple pair of scissors will just do the trick and be as safe. Now, pitfall number 7 is powerful staples. Staples are very powerful nowadays, right? Powered, they are nicely angulated. But beware, the jaw still needs to be looked after, the firing strength, and please check your staple line. Even a circular staple can be traumatic if it's angulated wrongly. So let's look at this video here. We've got a nice rectal stump after a transection of the rectal sigmoid. There's a little bit of difficulty because of previous endometriosis, probably trying to get up the rectum, all right? And lo and behold, when we see it, we see a bit of blue, a bit of that circular staple poking through. That is one pitfall. And really how to manage this pitfall, we've gone on to go lower down and transect lower down and discard that piece of bowel. Thankfully, it was a high anastomosis and we can't do that. So really summarizing the pitfalls, look out for the heat from energy devices. Forceps, you need to be aware of. Staple jaws, you need to be aware of. But more importantly, look out for unseen surgery, injury. If you see bleeding sources around places that you shouldn't have blood, look out for diathermy injuries, serosal tears, or an unknown vascular injury. Pitfall number 8, what are the technical pitfalls? I think when you dissect out of the plane and not recognize it, you can get into trouble with adjacent structures, bowel preparation, and gauze use in laparoscopy. So just look like this picture. The trainee was getting out of plane in the mesentery and continued to do it. The pitfall is that you should recognize that you're out of plane and get back in plane before you get into trouble. Next, a lot of things are nearer than we think. At the lateral rectal sigmoid dissection, the ureter is very close. If you're too engrossed with TME, you get that small bowel injury with the right iliac fossa port. And the vaginal wall is always closer than you think in a low anterior resection anastomosis. Just like here, the ureter. Bowel prep or lack of bowel prep, it is a pitfall. A lot of times we don't think about it, but if you feel balls of stools or bad bowel preparation, be prepared to do a colostomy and distal washout to prevent leak complications. I like to use a lap gauze, but really, you lose a lap gauze in laparoscopy, you can find a long time finding it between the bowel loops, and a one-for-one exchange is a good practice. Finally, pitfall number 9, we have a post-LAR anastomotic bleed. So we have checked the anastomosis. There was no air leak, but there was a lot of blood coming out. And how to manage a pitfall is at least have the instruments in hand. So we always have a colonoscope in my theater so that we can manage some of these. And then when the colonoscope goes in, we can manage it by using a clip on the staple line rather than redoing the anastomosis. Next, what happened for this low rectal anastomosis is that we have a pre-sacral bleeding. All right, it went on for a while. We transfused blood, we staple away the rectum, and now we're managing it. And this is another pitfall. Is commonly when we see this, we heart are thumping, we don't know what to do, and how can we manage this laparoscopically? Should we convert to open? But really, it's better. The best view is through the laparoscopy. So we put in some surgery cell, and then we think out of the box, what can we do? And then finally, we thought about a metal, what do we call tackers? So we use the tackers, tack the surgery cell in, all right, to tamponade it. And if you look at the end result, it is very well done. The bleeding has stopped, and we carry on with the surgery, completed the surgery nicely with only 1 packet of transfusion. So let's get the summary. What is good laparoscopic surgery? Good patient selection, knowing the nuts and bolts of your OR theater as well as a dedicated OR team. Good skills and experience knowing the pitfalls of laparoscopic instruments for access, dissection, grasping, energy, stapling, and anastomosis, and really be prepared for open conversion, for using adjunct equipment and staples, and getting a senior surgeon or proctor for help. And really how to manage pitfalls in laparoscopic surgery. Plan ahead, be safe, expect the unexpected, and be prepared to modify your technique to manage pitfalls. I thank you. I thank these people for acknowledgement from my professors as well as my colleagues and APELS and Olympus. And I sit down here in Singapore, hoping to visit all of you and for all of you to visit me in Singapore soon. Thank you very much.
Thanks, Dr. Lai. That was very good. Can I encourage anyone who's got questions to submit them through the chat function? And we're going to have some questions for you in the Q&A as well. So we'll be doing some live polling and getting you as audience members to participate as well. Next, we're very lucky to have some nursing involvement with this webinar today. And Mr. Vincent Chan from Hong Kong is going to be next. He's an OT supervisor at the Hong Kong Sanatorium and Hospital, and also president of Hong Kong College of Perioperative Nursing, and a council member of the Hong Kong Academy of Nursing. And today he's going to talk about 10 tips and tricks for nurses to enhance work efficiency in the OR.
Thanks for Professor Chris' light introduction, and also thanks for APEL's kind invitation. Okay, I will share the screen to all of you. Okay. Welcome everyone. It's my honor today to share some tips and tricks with you so that we will be better efficiency in OT. My job is very simple as an OT supervisor. I have to make sure that my department staff are all competent and make proper arrangement of OT rooms, staff, equipment for maximum utility. And also I make sure that my department has a good job satisfaction. How can I achieve all this? Let's find out today. As an OT manager, I'm always consider myself as a conductor of an orchestra. This is my responsibility to determine the daily course of the OT to maximum the OT output and orchestrate the pieces that ensure the smooth and safe OT operation. To overview, this is a critical, we have a super efficiency at the OT. Now what you can see here are all outcomes to be achieved to make sure that some patients are getting help and lives being saved. In this presentation, I will explain in detail about what we should do to make this reality. The question is, how can a manager orchestrate the nurses for high efficiency in OT? Now in Chinese, we have a saying, 工欲善其事，必先利其器. It's meant to a perfect task. One shall make sure the tools are sharp. The first tip for enhancing OT efficiency is enhancement of instrument and equipment. Sometimes I would say there are complaints from a surgeon. For example, they complained about the long sharpened edge of the laparoscopic scissor, blurred vision while using the endo-eye telescope, and much more. Now, this problem not only affects surgeon performance during the operation. My OT nurses actually were getting frustrated because they couldn't do anything about it. So the OT manager must have a mindset to make sure that instrument and equipment are well functioning and updated to keep pace with advanced surgical technology and surgeon technique to ensure the possible positive outcomes such as operational performance, surgeon satisfaction, and patient safety. OT runs 24 hours in 7 days. and every shift is managed by an experienced nurse to overlook all parts of the operation. He or she is a duty in charge to facilitate the arrangement of OT room, instrument, staff member with ultimate goal of running the services efficiency and safety. But nowadays, the greatest challenge for the duty in charge, I would say, is to show genuine care and understanding of staff physical and psychological needs. For example, the duty in charge should arrange the schedule well so that the nurses can spend at least 30 minutes on their meals. It is common sense. No food, low energy. On the other hand, everyone in OT is working in a high pressure environment, and all of us want to be perfect at all times. When mistakes actually happen, the duty in charge should spare a moment to understand the cause of the mistake before jumping into conclusion. If the staff basic needs are being met, I would say the quality and quantity of the output will be enhanced. As an OTP efficiency, the staff working hours must be flexible. That's the problem. I would say, who wants to work overtime for loving? Therefore, there should be some incentives, okay, to allow this flexibility of hours to happen. Like in my department, there's a system to call the staff coming back for a very complicated surgery. That requires the staff with sophisticated specialty skill and experience, and callback claim for emergency operation, also overtime claim for the same behind. All of them incentives are motivation for nurses to help special operation arrangement. Now, we can all agree that technology has reshaped the healthcare industry. Hybrid OR, robotic surgery has been already in place. AI will be the next trend in the surgery. This wonderful advancement has led to the increased surgical accuracy, safety, better patient outcomes. OT nurses must have a great attitude to learning to keep abreast of this new technology. OT manager also designate a nursing officer as an education coordinator to facilitate in-house training to make sure the staff involved in the operation have up-to-date knowledge on the technology. It is important we use training and professional developments as a tool to increase competency amongst the perioperative nurses. They can acquire the knowledge and skills for the professional and specialty qualification to meet the changing OT environments and technology demanding work. We all understand that everybody in OT is actually overworked all the time. Therefore, we need to be creative to streamline this entire operation process. I developed a new role, technical service assistant, TSA, who are not the nurses, but properly trained to assist in the operation with the aims of increasing efficiency and achieve the skills make model for effective manpower utilization. Evidence-based practice is also important. Now, what's the current trend nowadays? About 70% of all surgery performed nowadays use laparoscopic approach. Now, as you all know, the features of laparoscopic surgery are skill sophistication by surgeon, handling of instrument with tightest screw, smaller wound, and then viewing under the telescope. We are finding that in a laparoscopic surgery, counting and checking all items require excessive effort and time. And it is difficult to perform counting during a very short wound closure time. The question is it practical for the nurses to perform count for all accountable items through the operating procedure in laparoscopic surgery? Because of the hurried environments during wound closure, our nurses simply do not have enough time to check the integrity of the instrument. In addition, nurses are being distracted by the surgeon for a fast closure so that they may not be aware of the instrument integrity. Now, that could explain why we have incidents for retained tight screw or broken parts of laparoscopic instrument into the patient body cavity. Now, they actually have evidence-based support to illustrate counting laparoscopic instrument away in some occasion. That depends on organizational policy, of course. Literature also show that exceptions has been made based on the size of the instrument in relation to the wound, because I will say the instrument is much bigger than a wound. That is, it has the lowest possibility of being retained inside the body cavity. For used laparoscopic instrument, I will say log quantity. The most important point is to check immediately the integrity of the laparoscopic instrument when passing from the surgeon. Nursing specialty development is quite important and also the core element to enhance the nurse competency in OT. Now the question is, should we generalize or specialize the nursing practice in OT? The simple answer is both. While we need nurses to be well equipped with general skill in common procedure, we definitely see the advantage of the nurses having specialty skill and knowledge. In my department, I allocated 10 specialty nursing teams for 3 levels of nurses. I believe that when they are given opportunity to work in a designated team, they will become more familiar and professional with the up-to-date techniques required for the operation. As a result, they will feel more confident and develop great clinical partnership with surgeon and anesthesiologists, finally providing the good quality and efficiency operating services. As you all know, lots of problems are actually from miscommunication. That it could be about the technical information or simply as the personal feelings. We should foster a culture of good communication. In my department with over 200 staff members, there's a big family. There should be an effective channel for them to voice their opinion and feelings. They should not be hesitate to speak up when they see problems. So various WhatsApp groups are created to deliver the information from top to the bottom. I also make myself approachable and accessible, and to make sure I'm supportive of their hard work. I believe that better caring will lead to the better work satisfaction, loyalty, and then the work quality. Okay, the nature of our work in OT could be very draining. We may get tired from the tedious procedure day after day. Therefore, the final tip is to remain young and hard so that we don't get burned out so easily. How? We should keep our mind open to embrace challenges and learn new things. Now, here's the list of the 10 tips and tricks I share with you today. If I could use one word to summarize the entire presentation, I would like to use the word smooth to capture the philosophy of my procedure design and work environment. We want to make sure that our patient will receive the best treatment from our surgical team. To do that, every single part of the process, I would say, must be reasonable to all stakeholders so that they can perform at the best quality. As a result, the patient will not suffer from any mistake and error. Finally, we will be able to enjoy our work during this patient journey. Okay, this is my reference. Thank you for your attention. I hope you can bring something useful here back to your hospital. Thank you.
Thank you, Vincent. That was really very interesting. I enjoyed that. It's nice to hear from the nursing side of things, I think. Next up, we have Professor Michael Lee, who's known to us all. As we know, he's been doing minimally invasive and surgery in Hong Kong for some time now. And of course, he's the founder of APELS and the chairman at the moment as well. And today, he's going to talk to us about the 10 best practices to consider for building an effective OR. Professor Lee.
Thank you, Craig. My pleasure to give my presentation to you all. Give me a minute, just making sure this works. Okay, operating rooms are the proverbial heart of the hospital. Through a patient through OR impacts on all departments, even the A&E to ICU. Most costly area in the hospital, significant amount of investment as well as operating staff costs. So a well-managed and effective running OR can make a difference on the functional stability of a hospital. How to define operating room efficiency? Well, you can look at the first case start time, total case time, case cancellation rates, staff costs, turnover time, patient outcomes, and staff satisfaction. How to improve an OR efficiency? I think as we've been stressed before by Mr. Chan, teamwork among the surgical teams. I think operation cannot be performed with a single surgeon alone as such. Instead, it's a cooperation between different parties, namely the surgeon, the anesthetists, nurses, and assistants. So good communication and maintain harmony inside OR can allow the surgery to be performed smoothly. We must ensure patient is well prepared before operation, i.e. review the patient medical history and confirm he or she are fit for anesthesia. Review all the necessary imaging before operation, and the patient is consented about the operation, and prepare the antibiotic on induction, as well as make sure blood product is available if necessary. Briefing session before operation start. Well inform the nurses or staff about nature of OT and nurses' role in organizing OR. Well, how to set up the OR, how to prepare the patient, what instruments, equipment, and supply need to be prepared. So these are all the nurse's role. So with an organized OR, one can allow the surgical team to focus on surgical procedure and offer safe and convenient environment for them to work in. Briefing session before operation start. Nurse's role, how to set an OR is to how to prepare the patient, what instrument, equipment, and supply need to prepare. Location and monitor should be ergonomic to surgical team members. Optimize the choice and location of other equipment such as imaging system, energy sources. Additional operating accessory, anti-sliding foam in laparoscopic surgery, in particularly with heavy patient. What instrument is available? We need to have them for the surgeon. What do they need to supply the surgeon with? There is a very typical example of a trolley inside the OR with all the consumable, and the patient and the surgeon can instinctively summon the type or the size of the instrument they want for the consumable. Now coming back to minimal access surgery, it is not a new surgery, but a new procedure, but a new approach to the patient. So endoscopic surgery, laparoscopic surgery, both are MIS surgery. There are limitations in either of this approach. So the concept of endo-lap surgery came along, which is combining endoscopic surgery and laparoscopic surgery to ensure that we can have an endo-laparoscopic approach to disease. So i.e. the two procedures are complementary and have distinct roles. Example of some endo-laparoscopic surgery, just to give you for upper GI tract, you have intragastric tumor excision of benign GIST, HPB, intraoperative cholecystectomy during ECPD, or actually ERCP for common bile duct stone plus laparoscopic cholecystectomy at the same time. Lower GI, well, endoscopic leak test after bowel anastomosis, intraoperative localization of small colonic lesion, and laparoscopic assisted resection of flat colonic polyp. This is the Endo-Lap OR design that I envisioned back in 2005. Well, the first Endo-Lap OR was developed according to this plan, and you can see the real life picture here. And that was in 2005, and it was first installed in Asia. And in fact, we did some study to show that 30% reduction in OR setup time using Endo-Lap OR, 46% reduction in turnover time, and 60% reduction in time to set up additional scope. So this was published in Surgical Endoscopy. And following, we did a design of robotic Endo-Lap OR, and that was completed in 2009, in which we incorporated the Endo-Lap OR design with facilities to accommodate the robot, which is part of the MIS equipment. So you can see here that more improved, much larger OR to allow the additional equipment. And so now we move on to safe working environment. Endo-Lap OR would occupation safety is improved, turnover time is shortened. Now in our practice, we used to see one, do one, teach one. That was the old saying. We don't do that anymore. We actually teach see one, practice many, and then do one. So this is how we APELS workshop in teaching our trainees in simulator, practice on the porcine, training of POP, and even practicing on cadaver. Practice more before performing a real patient can improve patient safety, increases OR efficiency. Don't forget, chief surgeon is not the king in the OR. The assistant is very important, providing a secondary pair of hands and eyes. Their job is to point out the chief surgeon's mistake or dangerous action. This can further improve patient safety. Once again, the importance of practice, and that's why we have workshop, not just aimed at doctors, but nursing training workshop. It's also part of our regular program. As you can see here, nurses can train in a training center, doing various endo-laparoscopic procedure, practicing on a consumable, learning from the tutors the way to handle the instruments. So this is important that we promote collective information sharing, allow the team to identify defects, and praise the staff for the effort and contribution to improve the team spirit and job satisfaction. Well, to conclude, several key factors for an effective OR: teamwork, good communication, mutual respect among all parties. Most important, integrate OR design as the Endo-Lap OR. Regular evaluation on job performance, a lifelong training is required. Optimal working environment, can boost up staff morale, increase efficiency, reduce error, and ultimately improve patient surgical outcome. I thank you for your attention.
Thanks, Professor. That was very good. It's great to see how far Endo-Lap's come since 2005, really. Next up, my co-moderator, Dr. Joe Fan from Hong Kong, is going to talk. He's a surgeon and Chief of Service in the Department of Surgery, University of Hong Kong in Shenzhen Hospital in Shenzhen. And today, I've been very interested to hear what this is going to be about. He's going to talk about 10 amazing happenings in the OR. All yours, Joe. Let's see what it is.
Thanks, Rich. Let me figure out how to share my screen first. Well, can you see now?
You can see you.
We
Sorry.
had it for a moment. It's gone again, Joe.
Yeah. Okay, can you see now?
It's
Yes.
Okay,
Brilliant.
thank you for a kind introduction. And I'll talk about the 10 amazing happenings in operating theater, which will be very, very interesting. And our initial idea was to share with you to gather all the information from different sources to tell all our audience that anything can happen in operating theater. So nothing to disclose. So as I mentioned before, nothing is impossible in operating theater, which include medical related and also non-medical related. So the common error in the amazing things happening in OT, of course, the error in identity, site size, and medications. Of course, wrong patient entering the theater nowadays actually is not very, very possible because we carry out timeout and double checking all the time. Operating wrong side, sometimes it happens, but wrong operation we did encounter. For example, there was a case in the past that the patient suffering from carcinoma of thyroid, and supposedly the operation included the lymph node dissection, but it was not carried out during that time because the chief surgeon didn't pay attention to the clinical notes. So that's why the patient needs to be operation for the lymphadenectomy. Of course, the wrong concentration of drugs was being given in operating theater is actually, I think, is commonly encountered. Of course, the lost dangerous drug is also another problem. So that's why all these errors, and actually it did happen in OT from time to time. And so that it requires double and even triple checking before you give the drug to the patient, before start any procedure to make sure the patient's safety. Something medical related, of course, the chest drain. Of course, in laparoscopic or Endo-Lap colorectal resection, we seldom put chest drain for this kind of patient. But in some situation like the emergency trauma, we did put a chest drain for the patient. During the transferal of patient after operating theater or during after finishing the procedure, surgeon usually will leave the operating theater, but sometimes it will get dislodged, or actually our system will clamp the chest drain up during the patient transfer because they think it's even safer to clamp the chest drain, but in fact it is not the case. So other errors will happen, including no water in underwater seal and so on. So these are the problems that we encountered in the past and also from our past experiences. So this is a very interesting case that we encounter because of the wear and tear of the reusable instrument in operating theater. The gynecologist used the needle driver to do the suturing after hysterectomy. But unfortunately, the force she used was too forceful, and then there's some small parts of the laparoscopic needle driver was being dislodged from the instrument. And actually, at that time, they decided not to explore and to take out this little piece of a metal part from the patient. But under fluoroscopy and CT scan, we actually can see this metal actually inside the patient's body. Although you claim that this may not cause any problem to the patient, it won't cause any infection issue and so on, but in fact, the patient, of course, the team requests us to take this back to take out from the patient's abdomen. So what we did was, like in this video, there was a specially designed device, laparoscopic device by another hospital nearby. Is that there's a magnet in the front of the laparoscopic instrument so that it can retrieve the metal being dislodged inside the patient's body, especially, for example, this kind of little piece of metal parts, the sutures, the needles, and so on. So you can see actually this is not a single incident that we encounter here. So I think this is a very commonly encountered incident, especially when you use the laparoscopic instrument for many, many years without a proper maintenance, or actually you don't have the budget to buy a new instruments for the surgery. So another amazing incident that we encountered in the past is during the routine check of our staff locker in operating theater, you can find unused necrotics, sedative drugs, and propofol, and other different types of drugs inside their lockers. So some are half bottle and some are full bottles of drugs. And so this raised the issue that actually the proper disposal of dangerous drug is very, very important, especially in operating theater. And I think as far as I remember, in most of the locality, country, they don't carry out routine check of the personal lockers in operating theater. They just if the staff is leaving, then we clear up the lockers and give it back to the hospital operating theater, but we seldom carry out regular check of the personal lockers in OT. So that raises another issue that we should, on one hand, we should enforce the proper disposal of the dangerous drug. And on the other hand, we should check the so-called the personal lockers of all our staff in OT to make sure that there's no dangerous drug or dangerous devices or substances inside the lockers. So fell from operating table, I think this is another very serious incident. We encountered once in the past. It was at midnight. The patient fell from operating table after cesarean section during the patient transfer. It's all because of inadequate manpower during nighttime, and they didn't follow the procedure, the transfer protocol, and they didn't lock the transfer table. So that's when they try to move the patient from operating table to the transfer table, the table slipped and then the patient fell on the ground. So I think that is something amazing enough nowadays, because it seldom happens nowadays. But this actually, it really happens in real life. Fire on table, I guess most of you will heard this in the past. There are two different situations we'll encounter fire on table. Firstly, most of the time we use the alcoholic-based antiseptic, and also the grounding plate of the monopolar diaphragm will cause the explosion of sparks when you use the monopolar diaphragm. So the tips is ask the surgeon, especially the junior surgeon. Even for myself in the past, we tend to soak the operative field with antiseptic to make sure that all the areas are being still disinfected. But in fact, the more alcohol-based antiseptic you use, actually it doesn't mean that the antiseptic effect is actually will increase or will be better. And advise over to wipe all excessive antiseptic. But nowadays, actually, the evidence show that iodine-based antiseptic together with a initial swab of alcohol-based antiseptic is as effective as alcohol-based alone. So advice is don't use the excessive amount of alcoholic-based antiseptic solution. And another cause we encountered in the past in Hong Kong, that was many years ago, a male surgeon together with a female trainee during the tracheostomy. When they are using the diaphragm, there was explosion at that time. It all because of the oxygen and all the volatile gas for anesthesia causing this explosion. So I would like to share with you a few more non-surgical related incidents, but because it involves some of the gender issues, so I must be declare that there's no intention on gender discrimination or any harassment, because I think it's very interesting. So I guess for all the faculties would know what this is, but maybe for some of the attendees, they do not know what this pager is for. In the past, we used this pager for the personal and or the hospital communication. And it's very common for the surgeon to put this pager on the in the operating theater and ask our nurses to reply the call for them. So in one fine day, as usual, the surgeon asked the nurse to read out, please read out the message in my pager. And the nurse replied that it's better to read it by yourself after finishing your operation. But the surgeon didn't aware of this. So just read out is fine. The message was, my husband will not be at home tonight, so you can come. So that reminds us to make sure that all personal message or your phone, please lock in the operating theater. And firemen in the operating theater, as I mentioned before, there are some time that we encounter fire, but in this case, it's different. There was a patient with a metal ring being put on the base of the penis and causes priapism and go to the operating theater. However, we couldn't find any suitable instrument to break the ring. So at that time, the team decided to ask the firemen to help to get some professional tools, the hydraulic saw and hydraulic scissors to cut the ring. So that's the amazing thing was there was a team of firemen going into operating theater to help out to our operation. So finally, fight in the operating theater due to some personal conflicts. I think it's seldom happening nowadays, but actually we do encounter in the past because of some personal issues. It's the issue that staff, I might say the anesthetists, there's some personal conflict. So that's why there's some small fight in the operating theater. So finally, I will show you some really medical related amazing things. So this was the operation data bank many years ago. And it went smoothly, but after some time, you can see there's some discoloration of the bowel. At that time, we thought maybe we injure some major vessel or cut the major vessels, causing this bowel ischemia. Actually, the ischemia all the way from the descending colon all the way even to the small bowel. It's really, really hard to imagine why this happened when we're doing the routine laparoscopic anterior resection. But finally, we found out that it's because the endotracheal tube was dislodged and the anesthetist was not in the theater. And the alarm was actually ringing heavily to alert that the saturation of the patient was decreasing and because of this dislodged endotracheal tube. So my conclusion is nothing is impossible in operating theater, and teamwork is very, very important, including our anesthetists, our assistant, our nurses, and we all have to pay attention to the details to make sure that we all work as a team and to ensure the patient's safety. And the final message is don't blame anyone in operating theater if anything happened. We learn from mistakes so that we can improve in future. As for the philosophy of APELS, we do encourage team building and team training. That what we did in the past in the animal laboratory. We even ask our trainees and nurses to carry a timeout before we carry out any animal procedures. So once again, thank you for your attention, and I hope that all of you can enjoy, and thank you very much.
Thanks, Joe. Very good. So we've got some time now for questions for all our presenters. And the best thing probably is if you submit them via the Q&A button down on your screen, and we can try and then get through them. We did have one for Vincent.
Hi. Here.
We've got one question here. How do you solve the problem of staff mix in theatre? What can you tell us about staff mix problems?
Okay. I think the concept of staff mix or skills mix model happens when you recruit a group of the non-nursing staff personnel, just like, okay, in hospital authority, I would say there are many technical service assistants to do the basic nursing related tasks in OT, just like help anesthesiologists, assist in induction, or maybe sometime they will be performed as a scrub nurse, as not scrub nurse, scrub role, and to perform the simple cases and setting up the theater, whatever. So maybe you may shift the nurses, okay, to do another job. For example, advanced skill development, maybe pre-op anesthetic assessment or case coordination. That will shift the nurses to do another things. Okay, so to take care of the patient in an advanced level. Even though the most important, I would say, is to make sure to define clearly the role and responsibility, the delineation between the nurses and TSA. Yeah.
Great, thanks. Dr. Lai, you started your talk talking about how when you walk into an OR and nothing's been set up for you and how you've got to start again. I know what you mean because that happens to me all the time as well. Do you plan ahead in those cases, or do you have set up that you always use, or how does it work? Do you just get there early?
I think when I talk about pitfalls, is understanding the pitfalls. So I understand the pitfalls of my organization quite well. So we have three main techniques. Number one is a file of my common procedures and what I want exactly, down to the insufflator, down to the monitor, the brand of the monitor and the brand of the instruments. So that's one. Number two is calling up a day beforehand, just to check casually to the nurse manager, not to offend people, to say that, hi, I've got a case tomorrow. Are there any questions? And then of course, an open-ended question may not be the best. The third will be, I would like to have this anti-slip mat. I would like to have this equipment. Is it ready, or do you need to order it in advance? So these are for the routine cases. I don't do, like, for example, I don't do TEMIS so regularly. So if I'm doing a TEMIS, then I'll call up a week in advance to just make sure things are brought. So there's nothing left to chance in the operating theater, as what my lecture shows. We've got to make it happen, and down to the littlest details, we've got to ensure, and also to maintain harmony. So it's not like checking on people, not to checking on the support staff, but more to, well, just make sure things happen, and a casual phone call together with the details that you written down in the file would probably suffice.
Good.
I've got a comment to make. We have a protocol in our hospital for the surgeon prefer what they call a Bible for the surgeon. I mean, all your preferences and everything, and that seemed to help very much with preparing the OR. But I still like to go in a little bit early and just to check everything is all right, just as I've said earlier. Because even with the Bible, as it's called, sometimes they can still get it wrong. Well, you can't blame people, but you know, you're the operator, so you should be checking everything is there for you to want to use.
Yeah, I agree, Prof. Prof. Lee, this is exactly what I learned from you as well.
So Michael, it was great to hear about Endo-Lap theatres and how things have developed. And it's great to see how APELS has gone on with providing training, which, as you said, is so important. Where are we going next with APELS, do you think, in this current environment we have?
Well, Craig, I'm not so pessimistic. because I think with the vaccination rate going up and maybe the future travel is easing off, we will meet again in the training center that we used to attend. And I think that is the fraternity is built on our friendship. APELS will go on because I already said to the vision of this easily be 10 years, because the practice of Endo-Lap, the facilities or Endo-Lap OR has still a long way to go. And our APELS workshop still got a long way to go.
Great, I hope so too. It's very difficult to leave Australia at the moment, so it'll be great when it all starts happening again. Good. I wonder if there are no further questions, if we move on to the next section, because a few minutes up our sleeve might be quite useful if there's more questions coming. So I'll hand over to Dr. Joe Fan if Joe wants to introduce the next speakers.
Yeah, thank you, Craig. Our next section is on the megatrend transforming the future of the Endo-Lap surgery. And I will chair the section. And our first speaker is Professor Yataka Santo. Professor Yataka Santo is the director of the Endoscopy Center and the chief endoscopy section of the National Cancer Center in Tokyo, and also professor at gastroenterology in Tokyo Medical University. And his talk today will be on the artificial intelligence. May Professor Yataka Santo, please. Yeah, please turn on your mic. We still couldn't hear you. We couldn't hear you for the time being. Maybe there's some problem with the microphone. No, we couldn't hear you for the time being. If there's some technical issues, may I now maybe we first invite Professor Philip Chu to give the talk first while Professor Santo is fixing up the microphone issues. Is Professor Philip Chu here?
Can you hear me?
Oh, yes, we can hear you now. Professor Santo, we can hear you now. Yeah, please start. Yeah, you can start now, Professor Santo.
Excuse me.
Yeah, we can hear you.
Proceed.
We can hear you now, Professor Santo. Can you hear us? Can you hear us, Professor Santo?
Yes.
If not, then maybe we can invite Professor Chu to give the talk first.
Excuse me. Okay. And I don't know why the maybe in the test, you can hear my
Yeah.
voice.
We can hear you now.
Okay. So, okay. Maybe I can be entered to the Zoom. That's better. Okay.
Okay, maybe we invite Professor Chiu to give the talk first. Professor Philip Chiu is currently a professor in the Department of Surgery of Prince of Wales Hospital in Chinese University of Hong Kong. And he also is a director of the Multi-Scale Medical Robotics Center in the Science Park in Hong Kong. And currently, also I'm collaborating with him in the testing of his new robot. And his talk today will be on robotic endoscopy. I guess this was something very interesting and to share with us. Professor Chiu also is a very famous upper GI surgeon in the world. And please give us a very, very interesting talk so that we can learn the new technology and innovation from you. Thank you very much, Professor Chiu.
Thank you so much, Dr. Joe Fan. Thank you, Joe. And we really my honor to share with you the robotic endoscopy. I'm going to share my presentation. Can you see that?
Yes, we can see it.
Okay, good. Okay, so it's about robotic endoscopy. And I think one of the major target of this robotic endoscopy is about treatment of early colorectal neoplasia by endoscopic submucosal dissection. So ESD has been developed by our Japanese endoscopist and colleague, and I think Professor Yutaka Saito is one of the pioneer in ESD procedure for the colorectum. The advantage is that it's not only a locally curative intent treatment, but also concept of organ preservation and a better post-operative outcome with a shorter hospital stay and the early return of GI function. Currently, ESD is being indicated a lesion with TIS or T1, and without invasive component on block resection necessary, then we proceed to ESD. Lesions like difficult to be removed by snare EMR, lateral spreading tumor, and also mucosal tumor with severe submucosal fibrosis or sporadic tumors in the chronic inflammatory condition like UC. But I think the performance of ESD has been quite challenging since its development. The adoption rate of ESD is still not high. One of the reasons is because of the difficulty in performance of the ESD. So this is a courtesy photo given to me from Professor Nakajima from Osaka University, showing one of the reasons is because the design of the therapeutic knife is attached to the end of the endoscope. So when you are manipulating the knife for dissection, you need to move your head with the knife. So which is very different from what we are actually day in day out doing using our two hands for dissection. So I think learning from the minimal invasive surgery with the development of a robotic system, as Joe introduced, I'm actually an upper GI surgeon. This is my procedure of doing laparoscopic D2 gastrectomy. You can see the robotic system actually helps a lot in standardizing the quality and safety of lymph node dissection at the hepatic artery and the splenic artery. So I think this technology may be necessary if we move therapeutic endoscopy to the next phase. For example, 3D or 4K imaging, tissue retraction and dissection with multitasking platforms, or tissue approximation device with the suturing and the stapling. So in collaboration with Professor Lawrence Poe from National University of Singapore and Professor Louis Fee, who is our chief engineer in this project from Nanyang Technological University in Singapore, we developed this master and safe transluminal endoscopic robot. And this robotic arm concept was built on a conventional double channel endoscope. By passing through a preclinical studies, we actually performed the first clinical trial in 2011. 3 patients from AIG in India and 2 patients from Hong Kong with early gastric cancer were treated by gastric ESD using this robotic system, the master robot. And you can see this is a proof of concept study, so that it's two robot arm built on the conventional double channel endoscope, and with the one arm for retraction and the other arm for dissection. So the concept is a little bit like the robotic surgery we are doing now. The surgeon is sitting away, controlling the two arms, and there will be an endoscopist holding the therapeutic endoscope, standing by the patient. So this system was only adequate for the first in-human study. So in order to bring this concept forward, a startup company was formed in Singapore called the Endomaster and developed this Endomaster EC system. It has a independently designed flexible endoscopic platform with built-in imaging system and free working channel, 2 for robotic arm and 1 for the accessory, and also an independent water jet system. So this is the concept of the Endomaster system. So there was a surgeon console and a patient side card. The 2 robot arm will be passing from this channel of the flexible endoscope. So, and then through this 2 robot arm, we will be performing the ESD procedure. So this system has been tested in preclinical study in a porcine model. This was published recently in GIE 2020. We actually performed this colorectal ESD trial, and as you may know, actually in the porcine model, we cannot go beyond the sigmoid, but this is a proof of concept study demonstrating the functionality of the 2 robot arm, and with a different direction of retraction, exposing the submucosa and dissecting the submucosa and prevent perforation over the muscularis propria layer. So with this adequate exposure of the submucosa, hopefully we can improve on the learning curve for the ESD procedure, and also to improve on the safety and efficacy in doing this colorectal ESD. So after the final part of the cutting here, then we can take the specimen out with the robotic system. So the results of this preclinical study on 5 porcine model showing the operative time is 73 minutes. The submucosal dissection time is 15 minutes. And the specimen that we can obtain is around 4 to 5 centimeters in size. So with the background of preclinical testing with a porcine model, we then embark on a clinical trial that was conducted in May 2020 at the Endoscopy Center of Prince of Wales Hospital, Chinese University of Hong Kong. So this is the setting of how we perform the robotic ESD using this Endomaster system. This is the setup of the room. You can see there would be anesthetists helping us to put the patient under for the end of the bed, and with one endoscopist standing by, and the nurse and also the surgeon sitting over the surgeon console. So this is a video to demonstrate the procedure. This lesion is situated at 90 centimeters from the anal verge, so deep at the proximal transverse colon. And you can see that this is there was a acute flexure, change. So, and we first put in the 2 robot arm, and you can see that when we insert this 2 robot arm, it's located at 6 o'clock and also the 9 o'clock position, and with a jugo action from the arm. So this is an action to relax the arm and improve on the functionality. And after the relaxation, then we start the mucosal incision by the right cautery robot arm. And you can see with the robot connecting to a diaphragm, we perform, which is ERB, wire-free. Then we perform the submucosal dissection and mucosal incision. So the submucosal solution we pre-injected will be the all-right gel from the Boston Scientific as well. And after adequate exposure of the mucosa, we use the left robot arm to grasp the mucosa and then perform submucosal dissection using the right robotic arm. So you can see the ergonomics of having the 2 arms for the ESD procedure. And you can see also that when we encounter bleeding at the submucosa, this robot arm will be able to stop by using a coagulation mode. So the dissection will be starting from the anal side, which is closer to the robot system, and we do not open up fully the mucosal incision, and then exposing the submucosa and perform submucosal dissection. So the exposure will not be only using the lifting action, but in fact, compression action over the colonic wall will be also important strategy to expose the submucosa. So you can see that this is something that we learn from using this new system. So we do not only lift up, but also compress on the colonic fold in order to expose the submucosa. So while exposing the submucosa at the back of this dissection, we need to be careful about the tumor border. We have to make sure that the tumor border is adequate with adequate margin. So we have to expose now over the posterior side of the lesion. So the system is designed to be dissecting from the near end to the far end. So at this moment, so we are exposing at the submucosa dissecting, and so hopefully, to stop the bleeding and avoid perforation. And of course, the patient is under general anesthesia at this moment because of the study protocol design. We wanted to allow the patient to be more stable. In the future, I guess this procedure can also be done under monitor anesthetic care, and so we can avoid, doing this under GA. So right now we are at the back end dissecting at the submucosa and then the mucosal margin. So this video is 4 times speed of the normal speed, and it lasts around 4.5 minutes. So this procedure lasts around 20 minutes. So to me, I think that there's an additional advantage by the use of this robot arm. And if the platform is stable, if the position of the tumor is adequately exposed, then the procedure is in fact quite smooth. So this is the final part of the procedure, and this is a specimen that we took out. So in the future, I think the robot system will not be only enhancing the dissection and the resection procedure, but with the development of the suturing, I believe that we would have more application of the robotic system, like management of GI emergency, perforation bleeding, or even morbid obesity procedure like endoscopic sleeve gastroplasty or endoscopic full fingers resection. So with the clinical trial, now we have 30 patients recruited, and hopefully with the development of a 3D endoscopic system, novel devices like suturing and dissection devices, and the automation through endoscopic robot with the AI technology, we can enhance the development of endoscopic surgery. Thank you very much. Joe, you are muted.
Oh, sorry. Thank you, Philip, for your very nice presentation on the endoscopic robot. And because of the time limitation, we'll leave the Q&A section in the later part of our discussion. So may I now introduce Professor Yukata Santo? We're going back to you.
Yeah. Can you hear me?
Yeah, sure. Very nice.
Okay. Very nice.
Your talk will be on artificial intelligence. So we'll hear more about on how we can apply AI in the medical field.
Yes. Thank you very much for your kind attention, and sorry for the mechanical trouble. I'm going to start my presentation. Could you see the artificial intelligence?
Yes, we can see it.
Okay, that's great. No COI for this presentation. And as you know, the new technology, including NBI, are defined as optical image enhanced endoscopy. And for colorectal endoscopic diagnosis, the tumor detection is the first step and the most important for colonoscopy. A 1% increase in ADR, adenoma detection rate, resulting in the 3% decrease in the risk of interval cancer and 5% decrease in the risk of fatal interval cancer. Therefore, the polyp detection is really important. And I'd like to show the result of our multi-center RCT Japan polyp study shortly. It is important to know that even after the 2-round baseline colonoscopy, advanced neoplasia, mainly composed of non-polypoid colorectal neoplasias, especially laterally spreading non-granular type in the right side colon. So for this kind of flat region, it's the target region for us to detect, to decrease the colorectal cancer deaths. And nowadays, endoscopy AI from 3 medical companies are approved by the PMDA in Japan and commercially available. NEC AI wise vision supporting endoscopists in detecting lesions and improving and enhancing diagnostic accuracy by bringing doctors and AI together. Published in scientific reports in 2019 from our group. Could you see any lesion in this endoscopy image? This is 1 centimeter depressed type region. Now NVI reveals a brownish area here. And after angiocarmine dye spray, depressed pure 0-2C lesion. And surprisingly, the medical AI could detect this pure 2C 1 centimeter lesion correctly, like this. And after crystallized staining, type 3S, 3L pit pattern observed, and endocytoscopic image showed the irregularity of nuclei arrangement, the EC classification type 3A. Now the end brain could diagnose the cancer or not using the AI technology. And en-bloc resection completed. Histology, intramucosal, well-differentiated tubular adenocarcinoma, and curative resection was achieved. And now, as presented before, we have 3 medical AI for colonoscopy commercially available. But you need to recognize one thing. Evaluation criteria for the performance evaluation test differed among the 3 companies this time. So it will be necessary to standardize them in the future. And next step is characterization. The pit pattern is clinically useful for polyp characterization and prediction of histology. And we have introduced JNET classification, that is magnified NBI classification, and now the unified and standardized classification in Japan. And the end brain is AI for polyp detection characterization, as well as EC diagnosis. Yes. This is the typical LST non-granular type, shoot depressed type in the ascending colon. Center depressed area. And after angiocarmine, you could see some depression. But pit pattern show type 3S. In small area, the erosion and fibroid low irregular. Endocytoscopic diagnosis and end brain AI diagnosis, EC type 3A, suggesting intermucosal carcinoma, no invasive cancer. End brain diagnosis is like a brain of Professor Kudo Mori Misawa. Yes, what's your plan? Maybe according to the endocytoscopic diagnosis, the ESD will be available. But this is the day of the ESD. With retroflexion, you could see the deep depression in the center. So how do you perform? Stop ESD, go to surgery, or still continue ESD? In this case, conventional endoscopic diagnosis suggesting SM deep invasion, but pit pattern and end brain diagnosis could be still the possibility of intermucosal. So I continue ESD. Fortunately, the en bloc resection completed without complication. And after en bloc resection, and histology revealed intermucosal carcinoma. And in the depressed area, the cancer invaded muscularis mucosa, but no lymphovascular invasion, budding grade 1, and R0 resection completed. So according to the JSCCR guideline, the curative resection without risk of lymph node metastasis. Future AI plan will be a multimodality AI to predict cancer, metastasis, and patient prognosis, including not only endoscopy image, but also the radiology image, including CT, pathology, clinical database, and genome data. And this is a slide from Dr. Aihara. The development of robotic surgery is more advanced in Hong Kong, presented by Professor Philip Chu, and also in the US than in Japan. These new technologies may also be very useful in accelerating ESD. Robotic ESD will be supported by new AI technology in the near future. After the widespread use of robotic ESD, we endoscopists only need to keep the scope for surgeon, Philip Chu. Even after the widespread use of AI, still all responsibility of the endoscopic diagnosis is for us. Therefore, we should learn the endoscopic diagnosis more and more. Thank you very much for your kind attention.
Thank you, Professor Santo. It's a really impressive system. No matter what brand is it, actually, I think it's a big development in endoscopy services. And again, we'll leave the Q&A section after this, at the end of this session. And may I now introduce our next speaker, my co-director of this course, Professor Craig Lynch, and who's a founding member of APELS and also very supportive to all the APELS activities. And currently, he is a famous colorectal surgeon in Melbourne. And his talk today will be on technology to avoid osmotic leak in colorectal surgery. Professor Craig Lynch, please.
Thanks, Joe. I'll just share my screen. Good. Can you see that there?
Yes, we can see it.
Excellent. So in terms of anastomotic leaks, they've been with us for a long time and still remain a problem. A lot of the things we've tried to do to change them really haven't dropped the leak rate to zero. Leaks cause a lot of trouble. They cause changes in oncological survival, poor quality of life, patients stay in hospital longer, and they cause a lot of extra cost. Now, some of the things that can predispose to a leak include having a bulky male pelvis for an ultra low, if the patient's malnourished or smokes or had radiation or obese. All these things can make leaks more likely. And what can we do to try and reduce that rate? Now, we all know during surgery, there's some of the things we can do during the surgery to try and get the anastomosis as good as we can. We know we've got to get the tissue together without any tension. We know that we can't leave a hole in the joint, and we know that tissue has to be nicely perfused. Now, all these problems are especially relevant for laparoscopy because sometimes we don't visualize the tissue as well as we can in real life because all we're seeing is a video representation of it, and it may not necessarily represent what's actually happening. So there's some basic things that we need to be aware of all the time, like not putting a twist in the colon when we anastomose it. But there's other things, apart from basic things like this, which we really need to be aware of. Like, let's start with a leak test for an anastomosis. It's something we often do, where we blow up the colon after we've joined it together with air, and we check for bubbles. So interestingly, when we look at the data for this, when we look at all the studies that have been done, it really doesn't show a significant difference between leaks and whether we do an air leak test or not. Now, that's interesting. It often shows that we've got to look at the right data. So if we actually look at the truly randomized data, we can see a difference, and it can often reduce the incidence of leak by doing an air leak test, reducing the incidence of clinical leak down to about 5%. What's interesting, if we, as Dr. Lai was talking about before, if we find a leak on an air leak test and repair it, those patients are at significantly higher chance of having an ongoing problem and an anastomotic leak later than if actually we don't find an air leak test, don't find a leak at air leak test. So this is about using technology and about doing endo-lap surgery. And I think using a colonoscope to do an air leak test is probably very important. Although when we look at the data, it's not really borne out. There's only been a few trials, and they would suggest that there are less clinical leaks if we properly look at an anastomosis with the colonoscope after we've done it. But I think also it's important to remember that if we colonoscopically assess our anastomosis, we can do something about it. Not only if there's a leak, but also if it's bleeding, we can put a clip on and do other things than just by insufflating the colon. So at laparoscopy, again, as I said, it's difficult to get a true representation of what we're actually looking at. How do we judge vascularity when we're looking at a video image? It's easy when it's in our hand because we can look at the tissue, we can see some bleeding, sometimes pulsatile bleeding can be tested, or we can feel an arterial pulse. Laparoscopically, that's all different. So we can use near-infrared fluorescence imaging, which is a nice real-time way of looking at tissue perfusion. It can also help us in other things like identifying ureters and bile ducts. And specifically for perfusion, we can use it when looking at anastomotic leaks. Indocyanine green is the dye we use. It's quite safe, really. It binds to proteins in blood, so it stays in the circulation and is slowly excreted in bile. It is important to remember that it does have some sodium iodide in it, so don't tend to use it in patients who have an iodine allergy. We know it's excreted in bile because if you wait long enough and look at the liver, all the ICG fluorescence will be in the liver. How does it work? Well, when you shine light of a specific wavelength, in the near-infrared wavelength, on the molecules of ICG, electrons get excited, and then as they lose that extra energy, they give off some fluorescent light, and which you can then detect if you have the right detector. So it's two sorts of light, one to excite it and then one to detect the fluorescence. So all we need is a system where we can generate both the right near-infrared light to excite the molecules and the dye itself, and then we can look at it. So these systems are becoming a lot more common now. We can see them on robots or in laparoscopic systems. And we can see as we quietly wait here that the fluorescence is starting to perfuse through the vessels and into the tissues. And the areas that are brightly green are nice and safe, and we can plan our resection margins and anastomosis based on that. We don't have to just do it inside the abdomen. We can exteriorize the colon. And here I'm holding the distal colon, looking for where I want to resect it by holding the laparoscope over the top of the specimen. And as the anaesthetist gives the drug, it quietly perfuses around, and we can watch and we can see the rate at which the tissue perfuses, and we can see a margin where there is an area of non-perfusion which we want to avoid leaving in the patient. We can even look endoscopically at the anastomosis from below, and again, make sure we can see a happy, healthy, perfused anastomosis at the end of the case. So there's been some trials on this. One from about 5 years ago was called Pillar 2. It was prospective. It had about 140 patients. And in this trial, about 10 patients had their surgical plan changed. That meant some of them had a shortened margin because it didn't look well enough perfused. And sometimes after doing the anastomosis, it was revised. And they had a very, very low rate of anastomotic leak, only 1.4%. And in those patients where they changed their plan, they had no leaks, and only a very small 2 leaks in those patients where it looked okay on fluorescent angiography. So this was all very promising. We've been using it ourselves for quite a while now. This is our last 100 patients, anterior sections, all with ICG. These are typical Australian patients. Our median BMI is about 26, and 26 of those patients had a BMI over 30. And we had a leak rate in that using fluorescence of about 1.9%. An interesting one of those was only a very late leak after the patient had finished adjuvant therapy. So collecting up the studies, it does seem to suggest that ICG does have a role in reducing anastomotic leak. It's probably not as simple as that in terms of the technology, because we're assessing it visually, but there's a lot to be thought about in terms of how quickly the fluorescence arrives, which may have something to do with blood flow, and the intensity of which it is. And this is something I think AI and machine learning is going to have a lot to do with in the future. So in terms of assessing what we see, I think this will become very much an AI-driven protocol. Unfortunately, Pillar 3 was published recently. This was a study looking to follow on from Pillar 2 and was truly randomized. Unfortunately, they had to stop it early because although they wanted almost 1,000 patients, they only got 347 who were eligible and randomly assigned. And the unfortunate thing really is there was no difference in anastomotic leak rate. Both groups had a leak rate of about 9%, which is disappointing and really doesn't sort of support that anything can be improved with fluorescence. So what's the difference, I think? This is something I think which can highlight that. There's another study where looking at fluorescence, they had a leak rate of only 4% in the ICG group, which was significantly less than their matched group of retrospective controls. And I think probably Pillar 3 shows us that if you're actually truly thinking about doing an anastomosis properly, you're probably also doing it better. And I think although fluorescence can add something to that, it does highlight how important it is to think about perfusion with whatever tools we have at our disposal when we're doing it properly. Often anastomosis happens at the end of a case, everyone's rushed, and I think this is where mistakes and problems can come in. So I think the importance is we need to really think about doing that anastomosis and checking perfusion. So when we're doing an anastomosis, there's a lot of things we need to think about to make it better. An air leak test is useful, but also endoscopic visualization of that anastomosis can be really important, and we can supplement that with fluorescence. And also the most important thing also is checking that our donuts look intact. Now, more and more ways of stapling our anastomosis are also coming to the fore, where technology and AI are starting to have a role. Up until now, we've often just stapled, put a stapler across the rectum and fired it. And if it's thick tissue, we've had to squeeze harder, but we've still fired it. Now we're getting a lot more technology built into staplers, such that when we clamp the rectum, it'll assess the proper compression and it won't fire until that compression's appropriate. And we know that to form a proper staple and get a nice watertight and airtight anastomosis, staple formation is important. So putting this technology in the stapler and algorithms to really assess what's happening when we staple are becoming more common across all sorts of staplers and very useful in reducing anastomotic leaks. This robotic stapler here, you can see, needed to be placed twice before we were allowed to fire it. And when the compression meets the algorithm and is an appropriate compression and thickness of tissue, then we're allowed to fire the stapler and we'll have optimum staples formed. And interestingly, there's only been a few studies looking at this, but it looks like we can get a more airtight staple line out of a robotic or AI assisted stapler than we can a standard laparoscopic stapler. So I think watch this space. Certainly more and more staplers will have technology like this built into it. And it's not really just power, it's actually assessing how we form the staples that's important, I think. So although this talk's really about technology, I think the next most interesting thing that's happening with anastomotic leaks is really thinking outside the square and beyond the technology. And we need to think about the microbiome and what's happening in the bowel, because this really does have significant impact on what's happening in terms of healing and increasing the number of leaks we get. Certainly, the way the bugs and bacteria in our bowel respond to surgical stress, bowel prep, and what happens during surgery influence how anastomoses heal. And if we have the wrong bacteria present, they can disrupt not only the joins between cells, but also in how a wound can heal and potentially increase the leak rate. And I think more and more work is going to be coming out about how the microbiome in general affects post-operative recovery and wound infections, but also in anastomotic leaks. So watch the space for the future. In terms of fluorescence angiography, it's very promising, I think. I don't think it means it's an excuse for not thinking about how we do an anastomosis. I probably think most importantly of all, we do need to concentrate on all the steps to get the best possible mechanical anastomosis we can form, but certainly adding fluorescence to it can help reduce the complications. And one last shot. It is a good technique to really be sure that we can know what's happening with our anastomosis prior to firing our stapler. So thank you very much. I hope that's useful and sort of happy to answer any questions. Sorry, Joe, I think you're on mute.
Yep, thank you, Craig. May I now, it's a Q&A section. May I now invite all our speakers and also our faculties to join our discussion. And there's one question from our audience that we routinely do the air leak test and pumping air into the rectal stump and also the anastomosis. Will there's some small leak due to the pressurized rectum and also the around anastomosis causing this kind of a small bubbles coming from in the water? So Craig, can you give us some idea?
I think you'll often get a few little bubbles trapped in the pelvis, and it's important to try and clear all those out and get a very still water level before you insufflate. But if you see bubbles, then you've got to be suspicious for a leak and then try and repair it. And, you know, there's techniques to do that. You can put a suture in things, maybe a clip from inside, and then retest to make sure you've got an airtight leak, an airtight anastomosis. Yeah,
I agree. Usually the even the pressurized environment won't cause any air coming out from the anastomosis.
No, if you're seeing bubbles, you've got to be suspicious. Yeah. And not only fix the leak, but then think about defunctioning the patient as well.
Yeah, agree. So any questions from our faculties and floor? I want to ask Philip, Professor Jiunn.
Yes.
So it's a very nice instrument to do the robotic ESD. But I want to know in the current version, is it you're using the routine endoscopy with the robotic devices inserted to the operating channel, or is a specially designed endoscope?
Thank you, Joe. It's in fact a new platform. So totally new designed flexible endoscope. It's designed for colonoscopy. But the the system will be able to capable of doing routine endoscopy, but you probably don't want to use that. So it's more reserved for the robotic system.
So I guess the diameter of the endoscope will be something around maybe 1.5 to 2 centimeters.
Less than two.
So it's still possible to insert through the mouth and into the esophagus, passing the cricopharynges. Yeah,
I think so. Totally feasible.
So that in that case, usually you advise to do it under the monitor anesthetic care at least, right?
Yes, at least.
Okay. So far, what in your opinion, what's the limitation at the current version?
I think actually if you can reach the lesion, if you can put it at around in the from 3 o'clock all the way to 12 o'clock, I think then the system will be working perfectly. So the only limitation is that if your lesion is over 1 to 2 o'clock position, then the robot arm cannot reach that area because it's of the design limitation. So, but then of course, if you can change the patient position and the scope position, then I think everything can be done.
I saw the robotic arm as actually coming from the 9 o'clock and 6 o'clock position, right?
Yes.
I see. So that's why there's some limitation at the upper end of this area.
Yes.
I see. Thank you very much. And there's one question from the floor to Professor Sato. He want to ask what's the limitation in AI in surgery? Currently, the limitation in the field of AI in the application of endoscopy and also probably the surgical field.
Oh, thank you very much. Currently, the commercially available AI only for the diagnosis, but I believe in the near future, the AI technology will be widespread for the endoscopy insertion or endoscopic treatment, especially maybe robotic ESD or robotic surgery is good target for the AI application rather than our endoscopy, gastroenterologist endoscopy insertion, because the robotic procedure could be calculate the movement of the right hand or left hand, but in the endoscopy, it's a little bit difficult to apply AI technology.
Yeah, I agree. And I think everyone is thinking about to introduce AI for their endoscopy center to assist in polyp detection and so on. And one of the very important issues to consider, not just the AI itself, but also the system, the integration of the endoscopy together with the deep learning system, which is far more important than the AI identification, because I can see there's some software in the market that they sell separately the AI detection system without the endoscopy system. So that's why I think it's the integration for the whole unit is far more important than the software itself.
Yeah, but maybe you don't worry about that, because nowadays Olympus and Fujifilm, the endoscopy maker, is also developing their original AI. So they will sell the endoscopy system with combination of their AI system, maybe in the near from now.
So we are looking forward to the newer generation of the AI system, either in endoscopy and also in the robotic surgery.
Yeah,
and I got a question. I got a question to Professor Kate Lynch. So you have mentioned it's nearly for you the use of the ICG in your laparoscopic lap or colorectal resection. So the focus is on the bowel anastomosis, bowel perfusion before the anastomosis and after the anastomosis. So did you use the ICG for the identification of the major vessels during your dissection in the IMA, and also the maybe plus or minus preservation of the left colic artery when you're doing the initial vessel isolation and skeletonization?
No, I don't do that. Normally for any erectile resection I'll take the I'll take the IMA very high and formally mobilize the splenic flexure. Given that, I think it's very useful to use ICG because you really do see where your point of perfusion goes to. And if it's available, I'll certainly use it.
Yeah, I think the application not just limit to the at the end of the procedure or just before the anastomosis. Rather, we may apply it to the first part, to the vessel dissection, and during the procedure, we monitor the blood supply of the bowel before we decide on how much bowel we take and so on, right? So I think it's time to move to our next section, and I will co-chair with Professor Kate Lynch. And it's time for our trainee showtime. There will be 12 minutes for each trainee presentation and 4 minutes discussion. And today we invite 3 trainees from a different region, including Singapore, Hong Kong, and China, to present their case. And as we mentioned in the very beginning of our webinar, today's topic and also the theme will be on patient safety and how to choose the best option for the patients. So the topics of the presentation by our trainers will be focused on all these fine details of ensure patient safety and best care. So may I now introduce our first speaker from Singapore, Frederick, here?
Yes, I am, Prof. Yeah.
Yeah, Frederick is also is our good friend, currently associate consultant in colorectal service in the Sangkan General Hospital, Singapore, and he has been our APELS trainee in the past. Probably he will be the trainers in the very coming future. So the topic of his presentation today will be on the challenges in position for success and challenges in patient position and pelvic accentuation. Maybe you can start your presentation, Patrick.
Thank you so much, Dr. Pen. And I'd like to thank the entire APELS committee for giving me this privilege to speak. I'll be presenting on how we can position ourselves for success. And in this case, the challenges on patient positioning, as well as in dealing with a difficult case such as a pelvic accentuation. So this is a case I was personally involved in. I wasn't a main surgeon, but I'd like to bring the discussion through how we prepare and how we operated on this patient. So the first case, the case is about a 45-year-old Chinese gentleman. He smokes 12 sticks of cigarettes a day for the last 30 years. During the pre-operative workup, he was also found to have an isolated factor 11 deficiency. He has a family history of breast cancer, as well as a past medical history of previous fistula in anal back in 2012. He presented to my unit earlier in May with a locally advanced anal rectal adenocarcinoma, presenting with an acute presentation with rectal perforation from obstruction. He underwent then exploratory laparotomy, fecal decompression. Because of a redundant sigmoid that we see a lot here in Singapore, he underwent a sigmoidectomy and a double barrel colostomy, along with a biopsy of the tumor back in May. As you can see here in the different cuts of the CT images, there is a lot of fecaloma in the sigmoid colon, which resulted in the perforation, secondary to the obstruction from the tumor. And this is intraoperative photos showing the very redundant and dilated sigmoid colon. So after the procedure, he underwent a long course neoadjuvant chemoradiotherapy from July to September this year, and repeated imaging from CT and MRI shows a reduction in the tumor mass, as well as a reduction of the size of the pelvic sidewall lymph nodes and inguinal lymphadenopathy. The CAA also downtrended from 31 to 6.4. So this was the images. This was the patient's bottom in the 2 operations, one in May, before the neoadjuvant chemoradiotherapy long course, and subsequently that just in the next operation. This is the MRI images, pre and post neoadjuvant chemo RT, which actually shows a reduction in the tumor bulk, but the CRM was still involved. As such, After neoadjuvant chemoradiotherapy and a prehabilitation program with exercise and nutrition in Sengkang, he underwent an extra-levator APR, a coccygectomy, permacore mesh the perineum to avoid a perineal hernia. For the urological colleagues, they were intending to do a cystoprostatectomy as well as an ileoconduit creation. And for the reconstruction of the bum, they were planned to undergo a reconstruction of the perineal defect with bilateral gluteal YV advancement flap. So with such an extensive operation and anticipating long duration of operation, there were many considerations that we had. And it was a brainstorming session between all the lead surgeons from the various teams. And we came up with a few considerations and their potential problems, and we sought out to address all these potential problems. The very first thing is a prolonged procedure. Such a long procedure would inevitably put a patient in a stationary position for long duration hours, and you'll be at risk for venous thromboembolic events, and as well as pressure sores. There was also a need to flip him from a modified Lloyd Davis position to a prone position for the reconstruction. And with the needing to flip him from after the abdominal phase to the perineal phase, it requires safe and efficient positioning. There will also be potential problems such as a dislodgement of drains, which can be a catastrophe because after the abdomen is closed, if there's a dislodgement of drains, there will be a need to then reposition these drains after the reconstruction, which will then take or lengthen the already long operating hours. There's also a chance that there will be compression on the stomas, the ileoconduit as well as the end colostomy when he's on prone position, and this will then lead to stoma ischemia. There's also a difficulty in monitoring the viability of the stomas during the reconstruction phase when the patient is prone. And of course, there will also be a need to manage and expect intraoperative bleeding when we are going up the extra-levator APR near and doing the coccygectomy. There's also a need to offload reconstruction of the flaps, not just intraoperatively, but postoperatively. And this will avoid congestion of the flaps and ischemia, as well as to also bearing in mind that the patient needs to be kept in a comfortable position after the operation. So this is exactly what we did. This is a snapshot of what we actually did. So in preparation of the patient, before the patient was turned prone, we actually had ileoconduit colostomy, and we employed a two-table technique. So instead of using the same table and flipping the patient over, we had one Ashman table where the abdominal phase was conducted, and then he was flipped onto a Jackson's table and a spinal table in order for us to achieve an efficient flip with two separate tables. As you can see, in order to offload the pressure on the bony surfaces, there were a lot of epilex pressure relief adhesive that was stepped onto his knees and to potential pressure points. And of course, to avoid deep vein thrombosis or venous thrombotic events, and pneumatic cuff pumps were actually put on. This was prior to flipping, and of course, the face was also padded well because in a prone position for a long duration, there's not going to be a lot of facial edema. This is actually the Jackson's table with the Wilson's frame over here. And this allowed us to flip the patient prone while having the Wilson's frame on the Jackson's table allows the stomas to be not compressed during the long duration of reconstruction. At the same time, because of the Wilson's frame on the table, we were allowed to put on mirrors in between the frame and the table to allow the colorectal as the urological surgeons to monitor the stoma's viability and to check its positioning prior to the plastic surgeons starting their reconstruction. So there will be gel pads that also help alleviate the knees and keeping the knees at a slightly flexed angle to avoid hyperextension. And this is exactly how we do it. So as you can see, just like what Mr. Vincent Chan has mentioned, it literally looked like an orchestra. There was many surgeons and all hands on deck during the flipping procedure, and there was a dedicated personnel that was placed to care for the drains. This dedicated personnel was dedicated even prior to the surgery. So with that, we gently flip the patient over with commands from the head, and that's where the anesthetists comes in and cooperation is really required to gently flip the patient over while ensuring that everything that is supposed to remain in the patient remains in the patient and the patient doesn't fall off. So as you can see here, the patient is flipped prone from the Lloyd Davis or the supine position, and he was subsequently positioned well and checked to ensure that the stomas were not compressed prior to starting the surgery for reconstruction. So after the reconstruction phase, there were Prefner vacuum-assisted dressing that was put in to ensure that the wounds or the most critical areas of the flap was actually pressured offloaded. And on the picture on the right, we actually used the Z-Flow, which is a memory foam cushion pad around the patient's bottom in order to allow him to lie prone or to lie flat on the bed so that he doesn't require him to be prone throughout the entire duration of recovery. So after a good 14 hours, 2 pints of PEG cells, as well as 1,000 mils of blood loss, this is the specimen that was actually extracted, and this is the end result of the pelvis. As you can see, there's a long, narrow pelvis that we had to negotiate through. It was not bleeding, and at the same time, we could even see a satisfied surgeon's head from the other end. At the end of this 14-hour operation, this was the specimen, and we all commented that this was quite a lovely photo for and a very good case to demonstrate effective and efficient teamwork. So in conclusion, I think how to position ourselves for success in a difficult case is a priori identification of problems and thinking it through with the rest of the surgeons. And this has to be done way before the procedure. And in fact, we organized a Zoom meeting 1 week before with the nursing staff, the anesthetists, with the various surgical leads and their assistants to ensure that all these things were ironed out prior to surgery. We had to think out of the box, like what Dr. Lanjun has mentioned. We are all colorectal GI surgeons, but we had to make use or we had to thought of thinking of using the Jackson's table, which is the orthopedic spinal table, and the Wilson's frame in this surgical case. Of course, with effective communication and delegation of roles, then the orchestra can be conducted efficiently and effectively without time wasting and confusion. And of course, the best part and the most important part is the teamwork with like-minded and experienced colleagues. Of course, this case you probably wouldn't be, I myself would not be pursuing this case as the only surgeon, as we probably need a lot of proctorship experience from our senior colleagues, as well as all hands on deck in order to achieve the patient's best outcome. With that, I'd like to end my presentation. I'd like to thank the organizing committee again for giving me this privilege.
Well, thank you, Frederick. And any questions from our faculties?
Hi, Frederick. Jiunn here from Singapore. Very excellent surgery and actually illustrating all the pitfalls that was in my lecture. I wanted to ask you something about 3D printing and whether in your hospital and with your expertise of your previous head of department, Professor Chu, that this 3D printing technology, you think what is your opinion on its use for prior management of pitfalls, and also what is at the moment the current evidence-based management of 3D printing with relation to pelvic exenteration, as far as you know? Yeah.
Thank you, Dr. Lai, for the question. I think that's a very good question, and I think our plastic surgery colleagues are definitely using 3D printers. And I know that not only my hospital, but other hospitals are using such means to actually help, especially in reconstruction of facial fractures. In terms of the pelvic surgery, unfortunately, my institution hasn't really delved much into the use of the 3D printers. However, I do see its role in especially cases with altered anatomy. I think this is especially so in the dissection of the lymph nodes in the iliacs. I think if, let's say, we can identify or using the MRI or the CT images to reconstruct anatomical variants, then the surgeons can actually then appreciate where the various things lie, especially the iliac veins and near the obturator foramen. I think these are things that is worth the while looking into. Of course, 3D printing also comes with its cost. And in Singapore, the situation is that cost becomes a big issue with the government being very particular about cost efficiency in the patient's use. Of course, with emerging and increasing evidence in the use of such technology, then I guess it will gain more and more acceptance in the use in operations. Thank you.
Well, thank you, Frederick. Very nice presentation. One short question that you emphasize on the patient positioning and also teamwork on patient transferal. Did you think of using the simulation training center, use the training model to simulate the situation before the operation?
Yeah, that's a very good point. Thank you so much, Dr. Fan. Yeah, so in fact, we actually did come down to visualize the Jackson's table. I think Professor Chu, like what Dr. Lai has mentioned, actually walked down two hospitals, SGH as well as Sengkang Hospital, to evaluate what is the best modality or best equipment to be used for this case. We even then gathered critical members of the team down in MT-OT after hours to actually then simulate how the OT tables need to be moved and positioned in order to avoid, patient falling during transfer, or what's the width of the Wilson's frame that needs to be fixed at for the stoma not to be compressed. So yes, we actually did use some simulation prior to this surgery. Okay,
thank you. Thank you for the presentation. And may I remind all attendees that we'll have a polling section to vote who will be the best winner of this competition. So please stay until the end of this presentation and vote the presenter you like or your friend, and so that probably your vote will affect the final result of the winner. So may I pass the podium to Craig? You introduce the second speaker.
Sure, thanks, Joe. Next we have Dr. Ho Man Fung from Hong Kong. He's an associate consultant in the Department of Colorectal Surgery at the Prince of Wales Hospital in Hong Kong and an honorary assistant professor in the Chinese University. And today he's going to talk about ways to optimize patient safety and clinical outcome with patient positioning. Thank you.
Can you hear me?
We can.
So thank you, Professor Craig Lynch, for the introduction, and thank you, APELS, for the opportunities to allow me to speak alongside with great endoscopic surgeon and also endoscopists. So today, my talk, let me share my screen. So today my talk is will based on something more common daily routine about how to optimize the patient safety and clinical outcome on patient positioning. So this is more or less about the agenda. We talk about common position for colorectal surgery, complications related to patient positioning, steps for positioning, and things can go wrong, and how do we protect our patients. So common position, body position for colorectal surgery, I think most of us will use. In Endo-Lap theater, we are using the Lloyd-Davis position. And then for most of the laparoscopic procedure, lithotomy position and jackknife position are reserved for those complex perineal procedures. So according to previous studies, actually, lithotomy, Lloyd-Davis position is actually the most commonly used, as I've mentioned. And this position is actually of quite a high risk for complication, including venous thromboembolism, injury to nerves and soft tissues. So in laparoscopic colorectal resections and then in Endo-Lap theater, it's very crowded. And then we have to position the patient in an extreme position with the legs splitted so that we can have access to the anus. Also, the patient has to be put on head down position so that we have access to the pelvis during the section. And some of the time, we have to rotate the patient either to the left or right, and so as to displace the viscera away from the field of the section in a limited working space inside the peritoneum. So in such kind of extreme position, there will be complications related to this kind of positioning, including the impact of hemodynamics, respiratory system, soft tissue injury, venous thromboembolism, and also head and neck soft tissue congestion. So the incidence related to this kind of extreme positioning is actually highly variable, but according to a previous systemic review. However, there's common risk factors identified, including long operative time, extremes of BMI, as well as advanced age. So the classical description of positioning of patient for laparoscopic colorectal cancer surgery in Endo-Lap theater will be like decoupled position with hips and knees slightly flexed. Coccyx should be just off the operating table, and then the calves are well supported, protection of the fibula and also perineal nerve, as well as other bony prominence. And slight inclination depends on the areas requiring dissection. So this is a bit of video showing how do we position the patient. We've got the legs splitted, and then they are well protected with a leg supporter. The patient's upper limb has to be protected as well. The thumbs are pointing upwards so that they are in a neutral position, and the elbows should have been well padded and then tucked alongside the patient's body. Going back to the first video, and then both limbs has to be like positioned in a balanced position, so it will not put extra stress on one side compared with the other. And the support should not be in the popliteal fossa; they should be in the calf if you are using this kind of conventional leg supporter during endo-laparoscopic surgery. However, the patient can still move after the operation starts, despite this kind of fixation. This is because we need to move the patient in different body position, and then gravity will actually drive the patient off the table. This could be very dangerous. So this is a video on how do we test the patient on before the start of the surgery onto the rotation and in a Lloyd Davis position. You can see the head is a little bit off, and then when we rotate the patient, that would require the anesthetist to put additional head support so that there will not be any traction or compression injury to the patient head and neck on the brachial plexus during the surgery. So this is another video, and then the patient will put in rotation, and then the leg hit under the patient squat nurse bench. That we need to move the bench a little bit before we position the patient into optimum position for the section. So as we've mentioned, if the patient fall off in an extreme condition, we'll be in the surgeon and also the squat nurse will be in great stress. So we have all kinds of fixation devices, including the figure on the right-hand side showing Allen's boots, as well as soft paddings to the upper limb, so that the patient will not fall down despite in such an extreme positioning. However, is that all? But obviously it's not. What we want is not crucifying the patient on the operating table, but we want to protect the patient. So in order to prevent injury to the lower limb, preferably we should have this kind of lower limb support device called Allen strips. And then the pressure point should be well protected even if the feet are well in the boots. And we should have avoid extreme hips and knee positioning, and also so that the body weight of the patient will be on the ankle and also in the thigh. We also need to protect the patient's upper limb, as we've mentioned. The arms are tucked. If abduction is necessary, it should not be more than 90 degrees, hands in neutral position, and extra padding to the patient's elbow in order to avoid nerve injury. So like every position, and then there are pressure points. For most of the colorectal surgery, the pressure points are usually at the back of the patients, and they have to be well padded positioning during positioning. We also need to pay attention to the head and neck so that they have a normal alignment, also sometimes shoulder support. The face has also to be protected with covering so to avoid hitting by laparoscopic instrument. And of course, limitation of operating time in extreme position is also helpful to avoid head and neck congestion. So sometimes we need to position the patient in a very steep transdominal position, which is the definition is more than 25 degrees of inclination, usually for extensive pelvic surgery. And the patient will be at risk of slippage. As you can see, the anesthetist is checking very carefully on whether the patient has slipped. And after the start of the operation, the anesthetist has also to be continuously monitoring the patient for any complication arise from this kind of position. Also, we'll have additional protection device. Starting from the left-hand side will be additional shoulder support for extreme transdominal position. And then the picture in the middle showing we are doing robotic pelvic surgery, and then we strap across the patient with elastoplus with additional support to his shoulder so that the patient will not slip. Also, there will be commercially available anti-slippery mattress, which also avoid the patient from falling off from the operating table. And also they can have another function to reduce the shearing stress to the patient's skin. And of course, continuous reassessment by our anesthetic colleagues and also OR staff is important during the procedure. So this is my final slide, and with some take-home message. In order to protect your patient, having knowledge and awareness about how the patient to position and how the patient can get injured is important. We have to have appropriate equipment in order to protect our patient. Frequent assessment during the surgery by the operating team is important, and nonetheless, teamwork with all the OR staff in order to protect the patient, allow the patient safely going through the surgery is important. So this is the end of my presentation. Thank you very much for your kind attention.
Thanks, Dr. Ho. That was very good. If there's any questions from the panel, I think those pink pads you mentioned are very useful to stop patients slipping. There's nothing worse to lose access to the anus when you're trying to do your anastomosis if the patient slipped up the table, and having them appropriately positioned at the start of the case is important because it's very difficult to change position later.
Yeah, that's correct. And of course, the patient, if the patient can fall off, and then they can have all kinds of injuries and stuff. As laparoscopic surgery, you have all sorts of instruments and ports are on the patients.
I got a question to Dr. Ho. As you mentioned that our anesthetists and nurses will check at the head of the table to make sure patient not sleeping on the floor and make sure everything's all right. And did you think about the safety of the staff in the operating theater when they're checking the details of the patient? Because we did encounter some nurses or anesthetists hit their head when they're trying to accessing the remote position of the patient. So how do you find this issue? Is it preventable, or any measures that you can suggest to ensure the safety of the OT staff?
Yeah, thanks very much, Dr. Fan, for the question. And I think this is a very important question to address. And because in extreme position, usually the OT staff have to be lean very, very low. And then in the operating table where there's a lot of things that crowded. And then usually it's the anesthetist going down for checking, because usually that when the alarm rings, the anesthetist will go down and see what happens. Our usual practice is they have an OT assistant or a nurse helping the anesthetist to checking and protecting not only the patient, but also the anesthetist from hitting from the surroundings things like a trocar or everything around the patient. Because sometimes in endo-lap theater, I understand it could be very, very crowded when all the instruments and stacks are around.
Dr. Ho, this is Dr. Lai from Singapore. A very good, excellent description of protection and positioning. Can I ask, in your practice, is there a sort of protocol for steep Trendelenburg positions that we sometimes need, a lot of times need to do for example, a low anterior resection? What is your protocol for adjustment of this Trendelenburg? Because in my practice, we do some adjustments based on the time and phase of the different parts of the operation.
Yeah, because usually for extreme position, we are doing for a very difficult case that we might have to invite the robot to come in. But unfortunately, our institute does not have integrated table motion for robotic surgery. So that might be a useful asset if we can have to set up a protocol. But we usually have a fixed position, and then during the even in very complex rectal procedure when the robot is inside you. So it's just as my video has shown, we should have tested the position to see if the patient have anything falling off before we put on the drape on the patient. I think that could be useful because some patient of high BMI, they may have a more slipping down the table when they move into extreme position. Whereas the patient with low BMI, then the pressure point may have to be checked after rotation or positioning of the patient so as to minimize the pressure during a longer surgery.
Thank you.
Okay, thank you. We are keeping our time. So will be our last presentation by our trainee, Dr. Deng. Currently is a resident in the University of Hong Kong St. Hospital, colorectal division. And the topic he's going to talk about today is Endo-Lap approach for treatment of malignant sigmoid polyp. Dr. Dang, please.
Can you see my screen?
Not yet. You try to share the screen first. There's a button at the lower part of the screen showing you share screen. Seems there's some problem with the connection.
I think it's freeze.
Yes. Maybe it's too cold there. While Dr. Dang, we're waiting for Dr. Dang, I have a question to Dr. Ho again. And you have shown us there's some sensors putting at the back of the patient on the table to sense the pressure of the patient at the pressurized area. Can you give us more information on that? Because during your presentation, I thought of whether we can develop a system to wrap around the patient so that we can get all the information on the pressure on skin in different parts of the body so that we can prevent the pressure sore and other injuries to the patient while we're doing the surgery.
Yeah, I think we don't have that ping pad in our institution. I think it's just commercially available, but it should have been used for those very obese patients. Meanwhile, in our institution, in the general ward, there are some pressure sensors, but they are mainly used for like sensing whether the patient is leaving the bed or not. I think that is maybe useful if you just think the other way around, and then if there's excessive pressure, the alarm will goes off, and then this may signify excessive pressure that we might have to better protect the patient's back or pressure points in such case. But of course, using a more detailed sensor, then we can have like more information, like the picture has shown, and what is the highest pressure point, and we put additional paddings under that area during before the surgery starts.
Yeah, that's a very good system to detect whether the patient leaves the bed or not. It would be better to connect the device to a cell phone app so that we can monitor the patient's activity, and they can give some positive reinforcement and feedback to the patient that if they leave the bed for exercise and so on. And I also got a question for Frederick. And you have mentioned about the intra-op and perioperative management. I would like you to share with us the post-operative nursing difficulties in this patient, because I think it's really, really difficult to nurse this kind of patient in ward. And on one hand, we have to ensure enough mobilization, but on the other hand, the flap there shouldn't have any pressure, and we have to monitor the blood supply from time to time. So what's the difficulties in the post-op management, nursing management in this patient?
Right. Thanks so much for that, Dr. Pen. I think that's an absolutely great question, because I think regardless whatever we do during surgery and how well we do the surgery, if the post-operative management of the patient is implicated, then the patient also can't recover well. I think there's many folds or many facets to this. The first thing is, of course, we tackle the easiest thing first, which is the flap management. Typically, our plastics and reconstructive colleagues will not like the patient to be lying on the flap. However, you have already seen that the VY advancement flap will then actually prevent the patient from lying supine throughout the entire 2 to 3 weeks duration, which is almost unnatural for most of us. And asking him to lie laterally will then be lying on many drain tubings that is coming out from the back of the patient and from the front of the patient. So I think that's why we actually took about 2 weeks prior to the surgery to bring in this Z-foam, memory foam device or cushioning device that's commercially available to actually help offload the pressure or distribute the pressure evenly, even if the patient is lying supine, so that it actually offloads the pressure on the flap. Number two also is that we actually attach infrared devices to the devices onto the flaps in order to have a real-time monitoring of actually the flap perfusion oxygen saturation. So the moment the oxygen saturation is low, there will be an alarm that will set off to the plastic surgeons, and then they'll come telling the patient not to lie in that position anymore. And I think that's one aspect. The other aspect is also the drains and patients, medication, physiotherapies, dietitian, and of course something that we always miss, the chest physio. I think all these things needs to be reminded to the patient, not just after the operation, but they need to commit to all these things prior to the operation. And it needs a complete buy-in of the patients prior to the operation in order for him to comply after the op. Because after the op, there's going to be a lot of pain, a lot of inconvenience. He will then not want to do it. Yeah, so I think it's a lot of timely reminders. The patient is reminded by the colorectal surgeon, the urologist, the plastic surgeon, the nurses, the family. Then I think he will be nagged until he complies. I think then the last point I want to bring up is family support, because throughout the time at which the patient is in the hospital, the teams and the nurses can only pay attention to the patient very fleetingly during the morning rounds or the evening rounds. But the family comes in throughout the entire day, on and off during visiting hours, to constantly remind their loved ones that they need to comply with what the doctors and the nurses prescribe. Yeah, so I think these are the things in summary. Of course, there's many fine details. But I think these are the key principles that help us manage these difficult patients after the operation.
Yeah, great.
Thanks for the question. Yeah.
Very comprehensive answer to our the patient management. So
can I just ask Joe, how did they deal with his smoking while he was in bed for 2 weeks?
That's a very good question, Professor Lynch. I think the pure fact that we highlighted this was there was many months of convincing the patient to reduce his number of sticks of cigarettes a day. And the fortunate thing or the unfortunate thing is that we do have a good 3 to 4 months leading up to the surgery to try to get his number of sticks down. So he started off coming in emergently in May with 12 sticks a day. I think we got him down to about 2 to 4 sticks a day just prior to the surgery. Of course, post-surgery, we can put on nicotine patches. The good thing also is that now we are in the era of COVID. So the free movement of patients in and out of the wards is impossible. And therefore, they can't go down for smoke breaks and whatnot. And therefore, I think it helps in a certain way to prevent such patients from defaulting on the adherence not to smoke.
Yeah, we can tell him, we can pump him some smoke through the endotracheal tube. Okay, thank you very much. Now it's Dr. Tang's turn. The topic of presentation will be on Endo-Lap approach for treatment of malignant sigmoid polyp. Dr. Tang, are you here?
Yeah. Can you hear me?
Yes, sure. Please start.
Yeah. Okay, good afternoon, everyone. Yeah, because the Chinese mainland cannot apply for the Jiunn account, so I cannot set up my background just like others. Sorry. And good afternoon, professors and audience. First, I want to thank my boss, Professor Zhou Fan, giving me the chance to have a case presentation. And I come from the Hong Kong University, Shenzhen Hospital, China. And my case presentation topic is the Endo-Lap approach for the treatment of the malignant sigmoid polyp. And the patient is 55 years old lady and have hypertension before, and heavy check colonoscopy found polyp erection about 1.5 centimeter in the sigmoid colon, and it's about 26 centimeter from the endo verge. And the biopsy pathology showed that it's adenocarcinoma, and we arranged the checks and abdominal contrast CT found that is no evidence of the distant metastasis. So we arranged for the endoscopy localization and the laparoscopic anterior section for her, and the patient placed in the lithotomy position, and the chief surgeon stand on the right side, and the camera holder also stand on the right side of the patient, and the first assistant stand on the patient's left side. And this is the operations video. First, we placed a 10 millimeter laparoscopic shortcut under the belly button. And we scanned the abdominal scan organs and no found the metastasis. And then we put 3 5 millimeter shortcuts and 1 10 millimeter shortcuts for the operator. Because the location we cannot see in the abdominal, we arranged the endoscopy for the localization. And we open the sigmoid mesocolon. And expanding the top space. And we can see the separation of the sigmoid vessel and the vein. And then ligation of the IMA and the IMV. And then continue to separate it towards to the retroperitoneum. And open the retroperitoneum, and we can see the gauze we put inside. And then separate it to the preservative. And because the tumor is high, and we put the sigmoid out of the body and have the resection outside and have the hand structures hemostasis outside. Yeah, this is all the video. And post the operative, the patient received the liquidiol on the day 2, and the patient recovered well and discharged on the day 6. The pathology of the patient is the moderated differential adenocarcinoma, and the tumor is combined in the muscular layer and the no vascular and the nerves invasion, and all the lymph node is negative. And my question is now we know the patient. Now we know the patient's diagnosis is the T1 sigmoid tumor, just come from the polyp, and what the treatment is the more appropriate for her. The first is the endoscopy ultrasound and the endoscopy submucosal dissection, and the second is the endoscopy submucosal dissection combined with the laparoscopy, and the second is just like this patient, we perform the anterior sigmoid resection. And the second question is how to locate the tumor during the operation. First, we can use the methylene before the operation, but we know that the methylene bloom is maintained just for a short time. And the second is the endoscopy, just like this patient, use the endoscopic localization. And the third is use the nanocarbon. However, the nanocarbon is not reached in the mainland China right now, and which is more appropriate for her. And thank you for your attention. Thank you.
Well, thank you, Dr. Deng, for your presentation. This case highlight the challenges in a decision in the operation or treatment of malignant sigmoid polyp. We now welcome questions from our colleagues, faculties. I think one of the questions in mind is that why you didn't do the EMR or ESD instead of doing the laparoscopic resection for this patient, because the final pathology actually show only mucosal involvement of the malignant polyp.
Because
excuse me.
Excuse me.
Yes, Professor Sato.
Yes. So again, I saw the endoscopic image, and I also diagnosed SM deep invasive cancer from the endoscopic images. So could you show us the endoscopic image again?
Okay.
So in the colorectum, EUS is not so accurate for the depth diagnosis, especially for the polypoid type. And this is, the image is very small, but yeah, this region definitely SM deep invasive cancer from this endoscopic finding. So do you have the histology image as well?
Sorry, she has the colonoscopy from the outside hospital. We cannot get any picture from the colonoscopy before, because the first colonoscopy, you see the check, the pathology is the adenocarcinoma. So we think that is a malignant tumor. So we perform the operation. Yeah.
But biopsy, we didn't do any biopsy before endoscopic treatment, because even if the biopsy revealed carcinoma, the endoscopic estimation for the depth of invasion is the most important for choosing the ESD, EMR, or surgery. And in this case, looking the peripheral region, this is, and also we could see, observed very thick, the vessel and the surrounding mucosa. So maybe option is to see the histopathology again, or deeper cut of the resected specimen. Then SM deep invasion could be diagnosed. So in this kind of case, the discrepancy between the endoscopic diagnosis and histology, we should evaluate the histology, and you should ask for the pathologist. It's really important.
Yeah, agree. I think that one of the limitation in mainland China is we got too many surgical specimen for the pathologists. So that's why, unless there's a very clear indication, otherwise the cut and the pathology report won't be so detailed as Japanese is doing. So that's why it's good that we can go back and ask our pathologist to review whether there's any SM invasion like SM1 invasion to clarify the discrepancy between the endoscopic findings and also the pathological result.
Yeah.
So if in this case, do you think we should do a ESD instead?
No, because of course we also additionally performed the chrome endoscopy and magnified NBI and pit pattern, evaluate the tumor characterization and invasion depths, but just only this image of the white lights. So I could definitely diagnose this is SM deep invasive cancer, no indication for endoscopy.
Agree.
Laparoscopic surgery is the best option.
So any other questions or comments from our colleagues and our faculties?
This is Dr. Lai from Singapore. Dr. Teng, very nice presentation. Can I ask, based on the video that you showed and what you know of the patient operation, it looked like there was IMA and IMV was taken very nicely, but it looked like the IMA was taken either low or at just the junction of the sigmoid vessel. Is that the case? And what is the protocol in your hospital for doing that?
Yeah, we cut the IMA because the tumor is first is small, and second is no other evidence that he had the lymph node metastasis, and we think about the blood supply. So we just cut the six sigmoid artery and two of the sigmoid artery. Yeah, it's not in the end of the IMA. Yeah.
Actually, they're doing a trial or review on the patient with a rectal resection and whether preservation of the left colic artery will make an impact on the osmotic leakage. And as you may know that if there's any surgical complication in mainland China, it would be a tragedy. Even there's a kind of standard surgical complication, somehow the patient at the hospital or the insurance company have to pay for the complication. They have to some compensation to the patient, giving some money. So that's why every surgeon, every hospital in China, they are very, very cautious on any of the simple complication or morbidity associated with surgery. So that's why you can see even for ESD, it's not a very, very common procedure being done in China, because if there's any perforation, the patient may complain and sue you. And on the other hand, if there's any residual lesion or we prove that to be an SM invasion and so on, then patient have to repeat the procedure for laparoscopic resection. Again, they won't be satisfied, and then again they try to sue your hospital for money. So that's why there's some cultural difference, and also some different in the practice. Despite that, we have solid and evidence from randomized trial on the standard practice. So there's a question from the floor that how about the tattooing to the location of the tumor? Is it recommended? So Dr. Teng?
Yeah.
So there's a question to you. How about the tattooing to the location of the tumor?
Yeah, because during the operation we cannot see the tumor's location, and we have just have three methods to locate the tumor's location. First is the methylene, and the second is the nanocarbon, and the third is just like this patient used the endoscopy. But the nanocarbon is not raised in the China mainland, so it's a difficult for us to choose which is the more appropriate for this patient. If you don't want to use the endoscopy during the operation, you want to save time, you want to save the equipment, so it's difficult. Yeah.
Yeah, in Hong Kong we use Endo-Mark to mark the lesion before the procedure. The Endo-Mark usually stay inside the patient's body for at least 6 to 12 months because the macrophages phagocyze the carbon particles inside around that region, but it's not available in China. So the common practice that we'll use the methylene blue to inject the methylene blue around the lesion 1 to 2 days before the procedure, but the patient have to subject another endoscopy before the operation. So that's why sometimes they opt to do it intraoperatively to minimize the suffering of the patient and to localize the tumor in the operating theater.
Okay, thank you.
Okay, thank you, Dr. Teng. May I now invite Professor Kate Lynch to join our podium, and it's time to vote the best presenter.
Yes, everyone needs to vote. We have the 3 options, so cast your votes, please.
Yeah, based on their presentation skills, their topics, and the flow of the presentation, the time management, you can choose the best presenter in your mind. Or simply, if you have some friends here, and you can choose for your friends. But of course, we are surgeons, medical profession. Our choice will be based on scientific evidence. So please vote on your favorite presenter in the post that appear on the screen. So any questions or comments from our floor and our faculties? So I think it's a very good timing for us here to be together and share with us our experience. And we have 3 trainees today to present their work. And we appreciate their effort in contributing to education and also training in APELS group. Last but not the least, we'll announce the best presenter at the last part of our conference. So please also fill in the brief event evaluation for us so that we can continue to improve our webinar and also probably include topics that you like in future and improve our training. Maybe we can now have the live polling for the evaluation first. Karen?
So I think there's still a few left to vote, so keep voting.
So for those who haven't voted for the best presenter, please do it now. And then we'll start the evaluation soon. And then probably after that, we'll announce the best presenter of the day. And for your information, we have so far we have 3 centers. APELS will go to the Olympus Training Center for our APELS activity, including the one in China, in Guangzhou, and in Thailand, and also in South Korea. So usually we hold our APELS event in these 3 centers, and for each time we invite surgeons, trainers from different parts of the world, and also trainees from Southeast Asia, Asia Pacific area to join our training activities, which include the endoscopic and laparoscopic skills. Okay, now we can have our, yes, we can have our evaluation form. So please briefly fill in. So the first question is, do you enjoy today's webinar? And are you interested to join next time? And then what impressed you most? Yeah, for the what impressed you most, the choices can be multiple choice. Can be. So we are now waiting for the result of the voting for the best presenter. So maybe Professor Craig Lynch.
Thanks, Joe. I think they're still tabulating the votes, but I think it's been very close looking at the poll, actually. And tabulating the panel's views. I think Dr. Frederick takes the day. Just well done, sir.
Yep, congratulations, Frederick. I think
Thank
all
you so
the
much.
I think all of the trainees did a very good job in presenting their work. We take this opportunity to congratulate them. They have achieved a milestone and contribute to the patient's safety and care. We encourage you to join our activities in the coming future, probably as Professor Lee has mentioned, probably maybe in coming few months after the vaccination has been widely adopted, and then probably we can resume our activities. So the final words by Professor Craig Lynch.
Thank you everyone for joining today. It's been great to share some good talks and see some old friends again. I'm certainly looking forward to getting back to when we can teach APELS courses in person, because they're a lot of fun and I think everyone gets a lot out of them. Well done on the talks today to our 3 trainees. Excellent.
And also our faculties. So any final comment from Professor Lee? I guess he's preparing for his operation. If not, once again, thank you very much. And probably this ends our webinar. And we're looking forward to meet you again very soon. And of course, we're looking forward to our live physical meetings in anywhere in Southeast Asia and the Asia Pacific region. And again, thanks. Yes.
Thanks to all our Olympus staff as well for doing such a great job.
Yep. The last but not the least, Karen, Dora, who spent a lot of time organizing this activity and make it successful.